Welcome to Pharmacy to Dose, the critical care podcast, where we're discussing critical care and its pharmacotherapy in a fun and entertaining manner. And I'm your host, Nick Peters. And wherever you are and however you are listening, thank you. Now let's hear from our sponsor, QXMD, before starting off our great episode today. QXMD builds mobile solutions that drive evidence-based care in clinical practice. So check out READ for easy access to research personalized for you. Calculate for over 500 easy-to-use decision support tools, and Learn to earn CME online in minutes per day. Try them today at qxmd.com/apps. Again, that is qxmd.com/apps. Now, for those who may not know, Andrea Newsom and I co-lead the Pharmacy to Read book club, and we announced it a couple episodes earlier. But our next book is In Shock: My Journey from Death to Recovery and the Redemptive Power of Hope by Dr. Rana Audish. I think this will change the way that all of us practice as pharmacists in one way or another. And I think after these last 2 months, many of us really need some positivity in our lives, some optimism. And so the only assignment, right, I'm not a big homework guy, but the only assignment you have to do is just get the book and start reading or listening. Now, as easy as it may be to get the book, just go on to Amazon.com and search. Consider supporting kind of the independent bookstores. If you go to bookshop.org, that's book, and then the word shop, shop.org, when purchasing this book, that kind of can help the local independent bookstores around, and they're one of a growing number of industries that could certainly use our help at this time. And then if you're not a member of the Goodreads group, do that ASAP. Go to goodreads.com and then simply search Pharmacy to Read and join our group. Our discussion will likely start sometime in July, but more to come on that front. Now, the real reason that we're all listening today, I am lucky to be joined by Dr. Stephanie Bass to talk about acute liver failure. Now, the guidelines for the management of acute and acute on chronic liver failure in the ICU were released earlier this year. So what a perfect time to review some of those kind of new recommendations, as well as discuss some other treatment considerations for these patients. Now, Dr. Stephanie Bass is a medical ICU clinical pharmacist at the Cleveland Clinic in Cleveland, Ohio. She has a specialized practice area in the medical intensive liver unit. She received her PharmD from the University of North Carolina and completed her residency training at the Cleveland Clinic. Stephanie, thank you so much for joining today. How are you?
I'm great. Thanks for having me.
I'm glad you could join. Absolutely. Now, I have to ask, have you always been interested in the liver and kind of its disease management, or is this something that's grown on you just on, based on your post-residency practice site?
Yeah, I have always had some interest in the liver. Even during residency, I did a couple of projects looking at NAC. It's one of my favorite drugs, actually. But certainly the interest grew throughout my career and sort of evolved as the opportunity in this specialized unit that you mentioned kind of presented itself. I can tell you a little bit about this unit. Our MICU, which is comprised of 5 teams and 64 beds, has this large liver population in general. We take care of a lot of acute liver failure patients, acute on chronic liver failure patients, and end-stage liver disease patients. And about a year and a half ago, this opportunity presented itself for both me and one other of our MICU pharmacists to become more specialized. They needed 2 pharmacists to rotate on this new medical intensive liver unit, or we like to call it our milieu. So in this team, we try to put all of our MICU liver patients in one team, and we co-round daily with obviously both our ICU team, but also our hepatology team. Additionally, we do like a daily huddle with liver transplant coordinators for any of our liver transplant needs. And I know that there's some centers around the U.S. that have similar units, but my understanding is that a lot of these units are focused in the surgical ICU care of these patients, like both pre and post-transplant. And ours is a little bit unique in that it's focused on the medical ICU needs of these patients. So I guess to get back to your question, I would say that my interest has certainly grown with this opportunity. It's been really a very rewarding, unique opportunity for me professionally.
Yeah, I certainly believe that. What a unique chance to help these patients. Now, you mentioned that it's referred to as the milieu. Were there any names that were scrapped that were maybe considered, but then ultimately, in terms of kind of the nickname of the unit?
Yeah, there were. We proposed the liver ICU or the LICU, but that one got scrapped because that was just not appropriate.
Professionalism comes back to bite us, because that's such a perfect name. I'm all smiles right here as you said that. I've always said that the liver's my favorite organ. I think it's a little underappreciated, so I'm glad today we can kind of show the liver the love that it deserves.
Yes, for sure.
How is acute liver failure diagnosed? Is there a formal definition or some sort of set criteria, or is it more kind of based on clinical signs or symptoms?
Yeah, so there's a standard definition. It's defined as acute coagulopathy, really based on INR, an INR of 1.5 or more, and any degree of altered mental status, encephalopathy, any degree, without any pre-existing liver failure. I think a lot of times we always think of this as like the hyperacute patients, the Tylenol overdose type patients, but really the timeline of acute might not really be as acute as you might think. Because it can go all the way up to the past 26 weeks. And in fact, then it's further broken down based on that time from jaundice to encephalopathy. So as I mentioned, like the hyperacute, like the Tylenol overdoses, et cetera, is within 7 days. And then the acute liver failure is within 7 to 21 days, and subacute is within 21 days to 26 weeks. And often we can, a lot of times, figure out the etiology of liver failure based on that timing. So, for example, the etiologies associated with hyperacute, as I mentioned, is most commonly Tylenol overdose and shock liver, while things like our viral etiologies are associated with more of the acute onset.
So does having pre-existing hepatic disease, increase your risk of developing acute liver failure, maybe compared to someone with a healthy or normally functioning liver? Like, does that increase your risk for that? Maybe I guess I'm asking is, you mentioned those different types of presentations. Does having liver or hepatic disease increase your risk for a specific presentation compared to, like you said, I think the Tylenol hyperacute overdose is what a lot of us think of unless we practice in a unit that sees some more of these cirrhotic patients?
Yeah, sure. So typically, pre-existing liver disease does not increase your risk of acute liver failure. In fact, you mentioned the guidelines and how they kind of differentiate acute liver failure compared with acute on chronic liver failure. That's become kind of a newer category in the literature and kind of a separate diagnosis altogether, acute on chronic liver failure. So that's sort of how we've come to consider having that pre-existing liver disease. There are a couple of instances, a couple of etiologies where there may be some underlying liver disease, and we would still consider it acute liver failure. Those include like Wilson disease, hepatitis B, and autoimmune. But in general, I would say no, it doesn't really increase your risk, and we sort of instead classify it altogether as acute on chronic liver failure if underlying liver disease is known.
Now, we're going to be discussing many different treatments that go into the care of these patients, but kind of taking a step back to look at the big picture, what is our ultimate goal when treating someone with acute liver failure?
Yeah, so when we treat these patients, I think we have sort of two goals in mind. The first is avoiding transplant, and the other goal is really making sure these patients survive. So in studies, a lot of times we see this kind of group together as something called transplant-free survival. When you read a lot of studies of acute liver failure, that is the main outcome in the majority of studies. Some etiologies, though, mortality is really high outside of transplant. Some of those etiologies are like Wilson disease or autoimmune hepatitis. And in those cases, really our outcome of interest becomes getting them to transplant. And so if you look at those studies, sometimes you might just see an outcome of survival in general.
Now, do these patients present in a similar fashion, or does it really depend on the etiology? I know you mentioned that they'll all be coagulopathic and have some sort of encephalopathy, but in terms of their other organ system presentations, is it similar?
Yeah, there are some differences that you will see. I think even sometimes looking at their LFTs and their coagulopathies, I think you might see some differences. So, especially when you think about the hyperacute versus acute. So, if we think about the hyperacute, those a lot of times they see much higher LFTs. Just think of like our classic Tylenol overdose. The LFTs in those patients are super high, right? But some of the more acute or subacute etiologies, like the viral etiologies, you'll see much milder elevations in the LFTs and instead higher like INR and bilirubin. And then you mentioned like some of the other organ dysfunctions. Those are more, whereas every patient is going to have encephalopathy to some degree, some of the other organ dysfunctions are more classic with some etiology. So, for instance, renal dysfunction is pretty classic with like Tylenol overdose and mushroom poisoning, because they can get like a classic ATN type picture, where that may or may not be common or present in other etiologies.
So sometimes it can help you and give you clues, but sometimes it can be a little hard to differentiate.
Yep, for sure.
What are the most common reasons that patients present with acute liver failure? And then, maybe if possible, potentially compare what you maybe see in your unit versus maybe what's kind of reported or published about kind of national data.
Yeah, so Tylenol overdose is far and away the vast majority of cases, particularly I would say in the United States. In other countries, viral etiologies become more prevalent, but here in the United States, acetaminophen is the cause of more than 50% of cases, followed then by other drug-induced liver injury, and then other viruses, hepatitis A, etc. I would say as far as our unit, we're fairly similar to what's seen nationally, because we are a specialized liver transplant center. Sometimes we get some of those more rare etiologies transferred in. So we've seen, several cases of Wilson disease. There was one year when there was like a really wet fall, and there was a lot of the poisonous mushrooms bloomed, and so we got a lot of mushroom poisonings transferred in. So we have seen a lot of, or not a lot, but some of the more rare etiologies. But as far as like on the whole, we certainly kind of follow the national trends.
Now, two of the most, serious complications from acute liver failure, aside from, the most obvious of this, like you mentioned, are cerebral edema and intracranial hypertension. Now, is your treatment or management similar to neurocritical care patients who may have ICP or cerebral edema complications, or are you focused and targeting completely different goals just based on the etiology of it?
I think the general approach is similar to standard neurocritical care, especially if you have a patient that has known cerebral edema or elevated ICPs. First line we use osmotic agents such as mannitol or hypertonic saline boluses for acute control. And then again, if we know they have, elevated ICPs, we'll use hypertonic saline as continuous infusions for continued control, et cetera. So it's pretty standard neurocritical care treatment. I think the only additional thing that's not done in standard neurocritical care that we do is removal of ammonia, as that's the cause of cerebral edema. Lactulose is one option. Generally, it's not preferred in the acute, immediate pre-transplant period, because the bowel distension that lactulose can cause can make transplant a little bit more challenging. Generally, what we do a lot more, if we know it's causing cerebral edema for very elevated ammonia levels, we'll do things like high flow CVVHD or extracorporeal liver replacement devices such as Mars to kind of very rapidly remove high ammonia levels. Our center actually uses high flow CVVHD for that.
Oh, that's really interesting. I think we could have a whole discussion on kind of the management of cerebral edema and things. And luckily for all the listeners, if you haven't listened, Aaron Cook joined us to talk about cerebral edema and those issues, and it sounds like that might apply to these patients. So take a step back if you haven't, and definitely give that a listen. Now, there's not really, I guess when we think about these patients presenting, right, a lot of them are critically ill, and many of them, just based on their mental status, may be on the ventilator just due to, they can't protect their own airway. And so many of our commonly used sedatives and analgesics, as most of us know, they primarily undergo hepatic metabolism, which will certainly be altered or impaired in these patients. So how do you approach sedation and pain management? Are there maybe any empiric dosing changes or changes to kind of your management strategy when using these agents in acute liver failure?
Yeah, sedation and analgesia is maybe not the most common empiric dosage adjustment that I do, but it's certainly the drugs that I get the most questions about from providers. I don't do a lot of empiric dosage adjustments on these drugs in general, because the nice thing about many of these drugs is that, we titrate them to effect. And additionally, in acute liver failure, we try to avoid them in general because due to the fact that all these patients have encephalopathy as, a diagnostic criteria, these patients have to have frequent neurochecks. So we try not to use them unless, needed. But if they are needed, the drugs that I typically go to are for sedation, propofol, which although it is hepatically metabolized, if we think, back to how it's hepatically metabolized, the major pathway is non-CYP mediated. It goes through glucuronidation, which in acute liver failure usually preserves. If we think about end-stage liver disease, usually that isn't, it's usually preserved until you get to severe end-stage liver disease. So that's helpful. As far as analgesia, I still use fentanyl first line, even though it does go through CYP through A4 hepatic elimination, because we know it still has a pretty short half-life, even though that elimination, it will be prolonged in hepatic failure. And again, we can titrate to effect. Otherwise, if you want to use an alternate agent or if you want to get something intermittently, both hydromorphone and morphine, of course, go through non-CYP mediated glucuronidation, which, again, usually preserved in both acute liver failure and mild to moderate end-stage liver disease. So I usually feel pretty comfortable giving those drugs.
Is there an even stronger emphasis than normal in avoiding benzos? I try to avoid them. At least midazolam, I try to avoid. Both due to the CYP mediated pathway and also the frequent neurocheck needing frequent neurochecks. Now we've talked about this, but one of the requirements to meet that diagnosis for acute liver failure is the presence of encephalopathy, and you kind of talked about this when we were talking about cerebral edema and the use of lactulose and things. So let's dive a little bit further into that. What pharmacologic treatment do you initiate, if any, for symptom relief, or kind of like you maybe hinted at, does it depend on if we're thinking about transplant or not?
Yeah. So lactulose, even though, it has the concerns immediately prior to transplant, I think almost all acute liver failure patients, I think, will be started on lactulose to try to remove some ammonia, similar to how we give that for cirrhosis patients. As far as rifaximin, we don't use rifaximin really in acute liver failure patients. So kind of in general, for reduction of ammonia, lactulose will be used, typically though not immediately, if we know that they're going to transplant due to those concerns with bowel distension. For grade 3 or 4 encephalopathy, though when we know that the ammonia is high, we will do those more aggressive things that I've already mentioned, like high flow CVVHD or MARS, to try to get the ammonia down very quickly.
So it sounds like you may skip some of the, I guess you'd almost call them like the drugs in your back pocket. Like I know when I've been through one of those units when I was a resident, like zinc or metronidazole, there's like really shaky data for some of those, but it sounds like in your instance, you kind of go with the heavy hitter, and then if that doesn't work, you're moving on to extracorporeal kind of indications or things like CVVHD.
Yep, definitely.
And this is a question that I've kind of always wondered, and I'm curious what your practice is. When managing encephalopathy, should we be trending ammonia levels, or should we, kind of exclusively be following their mental status?
Yeah. So as far as that question comes up a lot, because the classic teaching in cirrhosis is not to trend ammonia levels, because the trend, once the ammonia is high, the trend doesn't really relate to the persistence or resolution in hepatic encephalopathy. But in acute liver failure, we do actually trend it. We trend them generally daily, sometimes even more frequently, because both the relative increase, so if we see that the ammonia level is rapidly rising, and also the absolute value, so an absolute value above 150 or more, are related to cerebral edema formation. So, and in either of those cases, those are the patients where we're going to be much more aggressive, and we're going to start things that I've already mentioned, like those MARS and high flow CVHD to try to rapidly remove ammonia.
That's an important clarification, I think, because that is definitely what we're taught with cirrhosis. And when you see, but they're both encephalopathic, right? But what we're concerned about is very different in these groups. So I think that's a really good clarification point. Now, NAC, in the treatment of acetaminophen overdose, I guess I should say N-acetylcysteine, or NAC, what we'll probably refer to it throughout the episode. I think that's one area of acute liver failure management that many of us are at least semi-familiar with, right? We remember the 21-hour dosing algorithm, the different weight-based parameters. But has anything changed with that? Do our, poison control colleagues still kind of recommend the same NAC treatment strategy that many of us learned in school?
Yeah, that's a question I get asked more and more about on rounds. So I would say for the vast majority of acetaminophen overdoses, that standard 21-hour IV NAC regimen is sufficient. But I think it is important to remember, when that question comes up on rounds, where that traditional dosing came from. I think hopefully we all remember that Rumac-Macue nomogram and that 150, line for that serum threshold for initiation. So there are a couple times when you might not consider doing that traditional 21-hour IV NAC regimen. So the first is actually in cases of acute liver failure. Sometimes you'll see recommendations to extend the duration, and that is probably often much more of a recommendation in acute liver failure. So the times when that's recommended is just continuing that last 100 milligram per kilo bag that runs over 16 hours, and they just recommend to continue that until there are declining LFTs, the patient is without encephalopathy, or there's an undetectable acetaminophen level. And that is a fairly common recommendation now. I think what's becoming a bit more controversial is in cases of massive overdose, if that 21-hour initial bag regimen is sufficient, particularly when we think about how NAC works as a glutathione store. So, in cases of massive overdose, it's conceivable that traditional dosing might not provide enough glutathione, and we might need to give even more. So the strategy that, you might sometimes hear that referred to as is doubling the dose, or instead of extending the dose, providing a higher dose. So in that case, what is sometimes recommended is providing that last bag is 200 milligrams per kilo over 16 hours instead of 100 milligrams per kilo over 16 hours. That was studied not in patients that had acute liver failure, actually. That was studied in patients that did not yet have hepatotoxicity, but all of those patients had massive overdoses. So instead of being over the 150 line, they actually were all over the 300 line. And they actually had significantly reduced odds of developing hepatotoxicity compared with those who received the standard dose. And in fact, I think this is pretty interesting. The only patients in the double dose group who actually developed hepatotoxicity had Tylenol levels above the 450 line. So some people think, maybe we should triple the dose or quadruple the dose or something like that. I don't know about that. That makes me a little nervous. But I think at this point, the data certainly suggests that extending is good, and that's frequently recommended. And I have certainly seen that poison control often recommends doing double the dose in patients that have massive overdose, which is either, if you can map it out on Rumac-Matthew above that 300 line, or, an ingestion above 30 grams or 500 milligrams per kilo.
Wow. So it's almost functioning as like a prevention, like a protective agent in the setting of the, massive overdose. That is interesting.
Right. Yeah.
And that's the phrase you said of, maybe 3 times as much. I think no matter where we are in critical care medicine, there's always going to be, if some is good, more has got to be better, right? We'll at least have to look into that.
Yes. I'm not quite convinced about that yet.
Now, when patients present with acute liver failure not due to Tylenol or acetaminophen, is there any role for the use of NAC as like a hepatoprotective agent?
Yes. So IV NAC can be used for non-acetaminophen-induced acute liver failure. In this case, it doesn't work as an antidote or a source of glutathione. Instead, as you mentioned, it acts as a free radical scavenger and can improve perfusion through vasodilation.
Now, what dosing regimen are you following? Is it the similar one, or like the one that the 21-hour infusion, or is it something modified from that?
So I have seen the 21-hour regimen used, but at my institution, we actually use this 72-hour regimen for that indication. That was studied in 2009 by Lee and colleagues in a randomized controlled trial in gastroenterology for specifically patients with non-acetaminophen-induced acute liver failure. If you're not familiar with that regimen, it's the first 21 hours are actually exactly like the acetaminophen overdose regimen. And then actually, basically, it's like what I just talked about with extending the duration. So that last bag is basically continued for 21 hours or for 72 hours. And in that study, they found no difference in overall survival at 3 weeks. But when, again, looking at transplant-free survival, they found improved rates of transplant-free survival, particularly in patients with low-grade encephalopathy at baseline and patients with hepatitis B and drug-induced liver injury as their etiologies of acute liver failure. So that's the regimen we use at our institution primarily. There are also some observational studies of NAC for this indication that show that you can actually continue that until resolution of the INR. So we have some hepatologists that actually recommend continuing it for even longer, but I think that really needs to be investigated further.
Yeah, or then you get the patient where you're on rounds and it's like, well, it's day 19 of the NAC infusion here.
Yeah, right.
So thus far, we've really talked and focused on things that were not included in the recently released guidelines. Now, I know many people may be wondering, like, wait, they didn't address those issues. It seems kind of like central or standard to these patients. And don't worry, there's an additional update, almost like a part 2, being released in the future. I think it's going to be later this year. Who knows? That was in the pre-COVID time when I knew that, so I'm not 100% sure. But what we can do is shift our discussion to kind of focusing on what is covered in these guidelines and kind of dig a little bit deeper into some of these things. Now, the first thing that stood out to me, and if you kind of look at, there's an executive summary that's got a really nice kind of, I think it's a 2-page table that kind of goes through these, and then they give some longer explanations later. But the one that stood out was the recommendation to use albumin for fluid resuscitation, especially when the serum albumin is low, defined as less than 3. So when using albumin in this manner for resuscitation, I mean, how are we doing this? Like, do you administer albumin until the serum albumin kind of reaches a specific threshold, until they're no longer fluid responsive, or do you do it some other way?
Yeah. And of course, an albumin recommendation always sparks interest for pharmacists. So this recommendation to use albumin really came from 2 different places. If you read the guidelines specifically, it came from some general cirrhosis management recommendations, such as like the use post-paracentesis. But the specific piece that you're pointing to came from actually the Albumin trial in severe sepsis and septic shock, and that's where it was, low serum albumin. I think the assumption that they made was assuming that patients with acute on chronic liver failure and acute liver failure would probably be hypoalbuminemic. I think of note, if you look at the Albumin study, a very small proportion of patients in the Albumin study had cirrhosis and liver failure. I mean, it was a very small proportion. So I'm kind of hesitant to extrapolate those results. And also, when we talked about the etiology of acute liver failure, the majority is hyperacute. And when we think about hyperacute liver failure, such as acetaminophen overdose, because of that time frame, a lot of those patients are unlikely to be hypoalbuminemic. So I think extrapolating those results, especially to acute liver failure, is a little bit hard. I don't recommend albumin for fluid resuscitation, especially to that serum albumin goal. Albumin for resuscitation has never really been studied explicitly in these patients. For patients with cirrhosis, of course, I still recommend albumin for those approved indications, post-paracentesis, HRS, SBP, etc. But specifically, if we're talking about albumin for fluid resuscitation, I don't recommend that. Instead, I recommend crystalloids.
What is your preferred crystalloid?
So, in acute liver failure, for patients with mild encephalopathy, grades 1 or 2, I recommend LR or normal saline. Usually, I like LR. However, in patients with grades 3 or 4 encephalopathy, we talked about previously, our need for maybe cerebral edema management and all that kind of stuff. My crystalloid of choice is actually normal saline due to the sodium content.
Yeah, this recommendation here, it's making it harder for us pharmacists out there to try to stop the albumin use. I'm sure that's a constant thing that you're trying to reduce on a daily basis.
Oh yeah, yeah, it's challenging for sure.
And if if we used it, kind of like if it's based off of some of the small data from the Albumin study, they targeted a serum albumin greater than 3. So I guess if we're forced to do that, that could be a way to potentially do that, right? Because that's what that study did, kind of gave the concentrated albumin until those levels got above 3, which makes sense that you said that because that's kind of in line with this recommendation. So it kind of all comes together.
Right.
The guidelines strongly recommend norepinephrine as the first-line vasopressor for the treatment of hypotension. Now, is there any time that you might consider other vasopressors as a first line treatment option, maybe compared to and leaving norepinephrine as an alternate agent?
No, norepi is first line. In almost all cases of acute liver failure, the driving force behind the hemodynamic instability is, your low SVR. So it makes sense here to use norepi first line. And that's what the guidelines, recommend. For second line, they recommend, or adjunctive, they recommend vasopressin. So it's very kind of similar in line with your typical surviving sepsis guideline recommendations as well. I will note a little bit about vasopressin. It kind of was a little bit interesting to me that they recommended vasopressin. I think it falls in line with our typical shock management, but I still use a bit of caution in patients with high-grade encephalopathy, grades 3 or 4, due to a very small study with terlipressin in patients with grade 4 encephalopathy and acute liver failure, which actually showed increases in ICP. Even though this really hasn't been shown with vasopressin, the AASLD guidelines from 2011 do caution its use. So my general practice in these patients is I certainly use it, but if it's needed for hemodynamic support, but I do, if they're monitoring ICPs, I make sure that it's not affecting it.
And you're not doing this in every single patient, right? You mentioned grade 4. So,
absolutely.
And at that point,
yeah, if they have,
yeah,
I don't worry about it if it's mild encephalopathy, grades 1 or 2. It really was that only study with grade 4 encephalopathy,
where you just want to try to do anything you can, and that even if it's a very small thing, if you have something else to do, you might as well try it. Yeah, absolutely.
Exactly.
So there's more and more kind of published research coming out supporting patient-specific blood pressure goals in the setting of shock. So how frequently do you alter your blood pressure goals in patients with acute liver failure who are concomitantly hypotensive?
So generally I use, a standard MAP target. The only time I would really target a different blood pressure goal is if I know that my ICP is elevated. And then, the target then becomes both blood pressure and CPP, just like in standard neurocritical care practice. Otherwise, I use a standard MAP goal of greater than 65.
Now, does this change if patients develop any other complications? Like the thing that comes to my mind is like hepatorenal syndrome. Like, is there any, do you ever kind of either, drive the pressure up or allow a lower MAP to get off of the vasopressors to kind of prevent that vasoconstriction?
Yeah, so hepatorenal syndrome is pretty rare in acute liver failure, but can develop in patients with acute on chronic liver failure. If it does develop, our target, we will adjust our MAP target. Usually then the target becomes 10 to 15 millimeters of mercury above baseline. So for instance, if our patient has a baseline MAP of 65, like that's where they live, then we would titrate our norepi to a MAP of 75 to 80.
And I guess my follow-up to that would be, do you really use in the management of acute liver failure, you're really focusing on that MAP target of greater than 65? Because I'm guessing many of these patients come in with none or very little medical history, right? And then maybe in that acute on chronic scenario where the patients who have cirrhosis, that's when you may have to think about adjusting blood pressures.
Yeah, we may or may not. Usually we use standard MAP targets. We don't. Most of the patients, you're right, most of them don't have a lot of past medical history, especially like our hyperacute acetaminophen overdose patients. You're right. So so we usually don't use anything off of our normal MAP targets. It's mainly our acute on chronic liver failure patients where if they have a history of cirrhosis or something, then their baseline MAP might be very low or something. And then we would maybe target a different baseline MAP.
Yes, I should have just asked you that directly. That's exactly what I was getting at. Was the lower MAP. So thank you. I should have just been direct. I went 20 steps when 2 would have done. So much to the happiness of many pharmacists, and one of those pharmacists, I'm looking directly at Brian Gilbert here, one of the previous guests of the podcast. The guidelines recommend the use of TEG to assess bleeding risk. Now, is this standard practice in your unit? Because I know, TEG requires a little bit of training. It requires machines, so it might not be universal per se. But do you all have them?
We do have TEG, and it is a standard practice. We haven't necessarily yet applied a certain protocol in terms of how we guide transfusions based on them. These recommendations are still fairly, new. They just came out a few months ago. But I was also very excited to see that the TEG guided transfusion requirements. We use them more for our cirrhotic patients than our acute liver failure patients right now. For our cirrhotic patients, particularly our cirrhotic patients that kind of have this ongoing bleeding that occurs, especially in our end-stage liver disease patients, we use daily TEGs currently to guide transfusion requirements. And in our acute liver failure patients, our general practice at this time is to check a TEG at baseline and then prior to any invasive procedures.
Now, for those who may be unfamiliar, generally speaking, how is the TEG different than, our standard, coagulation labs, like, for example, INR or APTT?
So, yeah, this is different because instead of looking at a single coagulation parameter, this is a measure of testing the efficiency of coagulation. So what happens is that the blood is rotated around a wire probe to activate coagulation, as well as the speed and strength of clot formation and clot lysis. And all of these outputs are measured. And from that, you can get estimations of clotting factors, platelet function, and fibrinolysis.
And so they recommend the use of TEG, and I'm wondering if that's because these coagulation labs, like a lot of them, are affected by hepatic function. So can you see in some of these patients that you can have false elevations, leading these patients to maybe having DVT prophylaxis held when, for example, they're at very high risk for clots? So can that lead to some of those kind of complications where the lab values lead you to kind of hold things that might be helpful for them?
Yeah, I find that that's actually something I frequently have to intervene on. So, recommending initiation of DVT prophylaxis when they've been held due to a high INR. And one way that maybe we can be a little bit more comfortable with that is by checking the TEG. Oftentimes when we check the TEG in these patients, the R value is often low. Interestingly enough, particularly I find that in acute liver failure patients, which indicates a hypercoagulable state in regards to their clotting factors despite an elevated INR. So, I frequently find that these patients are not on DVT prophylaxis due to that high INR.
And now, in the absence of bleeding, because obviously if someone is bleeding, you would need to, potentially give them a hemostatic agent. But in the absence of that, is there any role for pharmacologic correction of the, lab value associated coagulopathy?
Yeah, I don't recommend giving a pharmacologic reversal agent outside of, as you already said, bleeding, or sometimes prior to an invasive procedure, depending on what that invasive procedure is, based on the issues that you already brought up with the coagulation parameters in both acute liver failure and end-stage liver disease. There have been a couple of reversal agents that have been studied for in both of these settings. For acute liver failure, factor 7 has been shown to increase the number of ICP monitor placements, as has 4-factor PCCs. Our institution recommends, if they want to give it, 4-factor PCC prior to ICP monitor placement in acute liver failure, but we don't utilize the package insert dosing, as those dosing recommendations are based on INR, and we actually cap that dosing above an INR of 2. So again, if you use any of these reversal agents, you have to be aware of the issues we already mentioned with using INR in these patients as a marker of coagulation. And also you have to be aware of the increased risk of thrombosis. So if we talk, again about that patient that actually is hypercoagulable based on that ARD value, despite the elevated INR, and then if you give them a reversal agent, they're very likely, it's very likely to potentially cause thrombosis in that patient. Additionally, interesting studies of 4-factor PCC in patients with cirrhosis have shown inferior reversibility compared of, just the INR, compared to patients without liver disease. So I frequently tell my providers, if your goal is prior to procedure, you just want to make your numbers pretty, then it's unlikely to do that. So it's really just balancing your risk versus benefit.
That's a great way of phrasing it, because that's all you're doing, and if anything, potentially creating complications down the road. Now, there's an emphasis on the use of low molecular weight heparins for both VTE treatment and prophylaxis. Why do you think there's no discussion or recommendation on the use of unfractionated heparin?
So from my read of the guidelines, I think a lot of the data was extrapolated from cirrhosis patients, and this is one example of that. So the reason why there was the emphasis on low molecular weight heparin is because there was a study of low molecular weight heparin versus no prophylaxis in cirrhosis patients that found that there was lower risk of DVT and no increase in bleeding, which I think is great because this points back to some of the issues that we already talked about, meaning that these patients can safely get DVT prophylaxis. But because this study was done with low molecular weight heparin, the guidelines then recommend low molecular weight heparin. However, because there was not a similar study with unfractionated heparin, the guidelines didn't mention unfractionated heparin, but they did note that unfractionated heparin could be considered. My institution actually uses a lot of unfractionated heparin for prophylaxis in these patients because we had a lot of patients with renal dysfunction. So I think that's why they didn't mention it, but I also use it a lot for prophylaxis.
Okay, so when you can and when it's safe, their renal function is good, maybe using low molecular weight heparins, but for the patients that you would otherwise normally switch to unfractionated heparins, and it's probably okay to continue doing that.
Right.
Okay. Now, my favorite part of the entire guideline, hands down, there's no questions asked. It's recommendation number 31, and that is we recommend adjusting the doses of medications that undergo hepatic metabolism based on the patient's residual hepatic function. When available, a clinical pharmacist should be consulted. We just need to give a big round of applause to the two pharmacists on these guidelines. Near and dear friend of mine, Allie Killian, who practices down at Emory, and then William Peppard, who practices up in Wisconsin. I have zero faith that would have been added without pharmacists on the guideline writing, and it just shows, the emphasis on multidisciplinary, authorship is so important. Now that being
totally agree.
Yeah. Now that being said, anyone who's tried to go and look for hepatic dose adjustments, just like we do renal dose adjustments, turns out it's not that easy. So how do you adjust medication doses in acute liver failure? And do you have any maybe like go-to resources or references that you use frequently?
Yeah, I totally agree. I love the fact that they gave the shout out to the clinical pharmacist, but they don't provide a lot of guidance for the clinical pharmacist. But I think that's because, unfortunately, there aren't a lot of resources available. Some things that I use, some drugs do have if you look in your drug reference of choice, some drugs do have dosing adjustment recommendations based on child pube score, which is for cirrhosis. You can potentially assume that child pube class C is maybe equivalent to acute on chronic liver failure or acute liver failure, although I think that's a difficult extrapolation. I generally take a more reasonable approach of looking at just the pharmacokinetics section of your drug information resource and kind of basing it from there. So this is kind of what we talked about when we were discussing sedation, for instance. So if you see that the drug is substantially cleared by your CYP enzyme, you can assume that that clearance of the drugs will be reduced, and you need to reduce your dosing. Fortunately, your non-CYP clearance, phase 2, as you might recall from pharmacokinetics, is generally preserved in acute liver failure and mild to moderate in stage liver disease. So even if the drug is hepatically cleared, you can feel confident that your elimination is somewhat preserved until you get to really like end stage and liver disease or end stage cirrhosis, at which point you're going to even lose some of that phase 2 clearance as well. Some other considerations you have to think about include like bioavailability of your oral agents when we think about like that first pass hepatic so drugs that have like moderate to high hepatic extraction ratios, if we like remember that from pharmacokinetics, those drugs have significantly higher, actually will have higher oral bioavailability in acute liver failure and in stage liver disease because that hepatic extraction will be reduced. So some examples of those that we use commonly in the ICU are like oral metoprolol, midazolam, or morphine. So you might have to reduce those, or maybe I just try to avoid giving those drugs orally. So those are all like a very brief review of some considerations that I think you have to think about.
But it sounds like, unfortunately, for all of us, and and potentially, for you and your colleague, that there are very rarely simple, easy dosing recommendations. For the most part, you really have to look and use your brain and kind of clinical judgment.
Yeah, exactly.
Now, you hinted on this in kind of, talking about going to Mars, and we're not talking about the planet, kind of talking about the extracorporeal support. And some patients in acute liver failure, right, they need, like you mentioned, the high-dose CVVHD or even the use of Mars, like the liver dialysis, as part of their treatment plan. So these patients are unique, and dosing in these specific kind of circumstances can be challenging, and that's probably the understatement of the episode so far. So when you think about this, what kind of dosing considerations do you have for these critically ill patients? What kind of focus on, like, for the patients who are maybe receiving Mars therapy, where dosing recommendations just might be few and far between?
Yeah, for Mars, there's unfortunately not a lot of data here. I feel like I just keep saying the same thing. You can find a few pharmacokinetic studies in the literature, but I mean like a handful. Obviously, if there is therapeutic drug monitoring of the, do that if that's available. But similar to what I was discussing earlier with hepatically cleared drugs, I think it ultimately kind of comes down to using drug references and also the conceptual idea behind Mars. So Mars uses an albumin filter. So typically highly protein-bound drugs will be cleared by that filter. And additionally, it's important to remember that Mars itself is attached to a CVVHDS circuit. So you also need to make any renal dose adjustments as well.
Oh, that sounds pretty easy.
Yeah,
super easy. Just simple. Now, are there, you're going to be probably, like, at this point, you can probably look at a MAR and maybe find one or two drugs that instantly stand out to you that you may not like to use in these patients. Are there common medications that we should adjust or avoid that maybe some of us are just less familiar with? Obviously, the classic, like, avoid Tylenol and things, I think we all probably can understand and recognize. What are some maybe under-recognized or underappreciated meds to avoid as well?
Yeah, I mean, I try to avoid I I try to avoid, or we kind of already talked about some of these in like the sedation section. Like I try to avoid benzos, and I try to avoid Tylenol, or at least adjust it. Like I try to, if I can, we talked about SIP clearance if it's possible. Any drugs that are, if I can use something that goes through non-hepatic clearance versus like a renal clearance, then that's what I prefer. But I can't think of anything like super specific other than kind of what we talked about in the sedation section with like benzos that I really try to avoid. And even with benzos, it's like midazolam and stuff like that I really try to just make sure I avoid. But yeah, it's more of just I try to dose adjust if I can, but there's a lot of things that you can't just completely avoid.
Yeah, sometimes you just have a few necessary evils that you just kind of have to overcome.
Right.
Now, ultimately, many acute liver failure patients will be listed and then hopefully receive a liver transplant. But certainly not every patient is eligible for a liver transplant, for one reason or another. So for patients who are transplant candidates, because you mentioned this is certainly not everybody, how does that affect your treatment plan and kind of medication management strategy?
Yeah, if a patient is a candidate for liver transplant, either acute liver failure or end-stage liver disease, our focus from a medication standpoint really changes to optimize them for transplant, particularly as they come within that immediate pre-transplant window. So some things that we do in terms of a medication standpoint, we try to be very careful with sedation so that they can assess their mental status. If it's an acute liver failure, we're very aggressive in terms of tight sodium control. From a hemodynamic standpoint, the surgeons like to see, ideally they would like to see that they're not on any vasoactive agent, but if they are on like NorAPI, they're going to be on the lowest dose possible. So sometimes, especially for our end stage patients, we'll put them on like some high dose midostaurin to get that NorAPI dose down as much as possible. For empiric antibiotics, even if we suspect that their clinical picture is like secondary to their liver failure and not an infection, we'll put them on empiric antibiotics. The whole point becomes really to make them as fine-tuned as possible for transplant, because we know at that point their ultimate treatment goal becomes getting them to transplant. And so it kind of becomes a shift in your focus at that point in time.
Well, I don't know if this is old mantra or not, but one of the old kind of critical care hepatologists that I had worked with really emphasized that when you're in acute liver failure, you can be functionally immunosuppressed when your liver isn't working as well. So it makes sense that you would want to cover for anything before a potential transplant.
Yeah, for sure.
So Stephanie, this has been great. I mean, the amount of topics and things we've covered has been honestly impressive. Now, what if you had to kind of summarize or give a few highlights or key points that you want to try to make sure that everyone keeps in mind? What would those things that you'd want to reemphasize be?
Yeah, so maybe like 4 key points for a patient with acute liver failure. I think remembering that NAC is the pharmacologic treatment of choice really for all types of acute liver failure, even your non-acetaminophen induced. And consider using sometimes higher doses or extended durations, especially for some of those massive overdoses. The second thing is that neurologic complications are your most severe, and management includes control of ICPs. And I would say maybe don't be afraid to give patients normal saline, because I know that we think that might not always be the best thing, but sodium control is important. INR might fool you, so consider using PEG to guide your transfusions, and also, to tell you whether or not to give DVT prophylaxis. And the last thing is that pharmacokinetic principles are really key in these patients, just going back to the like basic PK stuff. So like, don't forget your basic drug elimination principles and protein binding principles and things like that.
Well, that was fantastic. Now we are closing in on about 2 months of quarantine life. You know, you're in Ohio, I'm in Indiana, so we're neighbors here in the Midwest. So what types of things have you been doing to pass the time? You know, are you on the sourdough bread train? You've been trying any new board games or card games, or what have you been doing to stay busy?
So I am not a baker. I'm not much of a chef at all. I haven't actually really picked up any new hobbies, but I've always been like an avid reader. In the pre-COVID era, I was actually in 2 monthly book clubs. So I think probably one of the biggest things I've done is just reading a ton. I've probably read a dozen or more books in the last couple months. And I've also spent a lot of time doing like, virtual calls and stuff with family and friends. And this is probably going to sound bad, but I feel like I'm in some ways like more connected to people that, like my family.
Absolutely
we're doing
true.
Yeah, like twice weekly calls, and we didn't do that beforehand. So I think it's actually a really good thing. But
now, are you a fiction or a nonfiction reader?
So the one thing I like about my book club is it's forcing me to read more nonfiction. I'm definitely a fiction reader, but some of the best books I've read recently have actually been nonfiction. So I'm getting into nonfiction, I would say.
I like that you mentioned reading, because I'm at the point now where I'm over TV. I'm over Netflix. Like I've had enough of it. I've definitely started trying to read more. You're in 2 monthly book clubs. So basically you're living out everyone's New Year's resolution of reading more books.
I try to stay. I'm not always like I try to read both the books each month, but sometimes I just, when we would actually have them, sometimes I would just socialize, but I almost always read the book.
Okay. Now for the last question here, I want to give you the floor to defend Cleveland, Ohio. I think the popular media, I think it gives Cleveland a bad rap. So I'm going to give you the floor to give us the insider perspective on why Cleveland rocks.
Okay. I'm happy to do that. I think Cleveland is really so great. I don't know why it gets this bad reputation. I'm going to maybe blame it on the Browns or something. I'm not sure. But in Cleveland's defense, I think a lot of people think about like the Rock and Roll Hall of Fame, as you mentioned, Cleveland Rock. So I'll say maybe like 3 things that I don't know if everybody knows, but I think of as like when I try to, advocate for Cleveland. These are the things I think of. Unfortunately, I think all of them are mainly shut down right now, but that's okay. Whenever anyone comes to visit Cleveland, these are the things you have to do. So first of all, we have really good food. We have amazing food. So I don't know if people know this, but Cleveland is home to several award-winning chefs like Michael Simon and people like that who've opened up lots of really amazing restaurants here. So if you come to Cleveland, you have to come hungry. And secondly, Playhouse Square is our theater district. It's the second largest in the country outside of New York City. Did you know that?
No, I did not know that. I did not.
Yeah. So if you come, you have to come after COVID when they're actually doing shows again, and you have to come see a show. And third, the Cleveland Orchestra is like literally one of the best in the world. They go all over the country, but their home base is here. I'm a season ticket holder, but of course they're not performing right now either. So hopefully, eventually you'll be able to do all those things. Catch a show at Playhouse Square and see the orchestra. And then everyone listening will realize that Cleveland is a great place to be.
Yeah, hand up, I didn't know any of that.
Yeah.
So you just passed along. Now, are they known specifically, Cleveland, for any type of like cuisine or thing like that? Or is it just there are just delicious restaurants all across the city?
I mean, a lot of the really good restaurants are like farm to table, but we have like a little Italy section of town and stuff like that. So, but I don't know that it's specific. It's not like, we have one specific food that we're known for, but yeah.
It's not like Kansas City with barbecue or something like that.
Exactly. No, okay. It's not like that.
Well, Stephanie, thank you so much for coming on and sharing so much knowledge with us all. This was incredibly insightful, and really appreciate your time.
Well, thanks for having me. This has been a lot of fun.
Now, what is the best way for the listeners to kind of get in touch with you or reach out? Like, are you on Twitter at all?
I am on Twitter. I don't tweet a lot. But they can certainly like message me if they want. But I'm not a Twitter person. Some people say that I'm a lurker. I like things on Twitter. But certainly, at Stephanie in Bath.
Oh, perfect. Well, thanks again, Stephanie. We really appreciate it.
All right. Thank you so much.
I want to give another big thank you to Stephanie Bass for joining us today, and also want to give a massive thank you to you, the listeners, because obviously this podcast doesn't exist without you. Now, please send me feedback, both positive and negative, as well as any guest or topic ideas. And these can be, COVID or non-COVID ideas. Twitter or Instagram at Pharmacy to Dose, that's TO to Dose, or via email at pharmacytodose@gmail.com. And then on our website, pharmacytodose.com, you'll find the show notes that include, some background readings, obviously a link to the guidelines we've talked about, articles we referenced, and much more. And then everyone who's still listening, call your mom, call your dad, a friend, anyone. It's definitely important to not lose touch in these times. So definitely reach out. It'll feel better for you, and the person you reach out to is going to really appreciate it as well. And until next time, I'm Nick Peters, and this is Pharmacy to Dose, the Critical Care Podcast.